بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على سيدنا رسول الله. I'm Dr. Mahmoud Hassan, cardiologist assistant consultant at King Fahd University Hospital. Today I will be an instructor for cardiovascular examination for the undergraduate medical students. I hope I can cover the required skills needed for the undergraduate medical students to pass a cardiovascular examination. Our cardiovascular examination, first we will start with hand washing. Then I will introduce myself to the patient and identify patient information and gain consent and checking for any pain or abnormal issues or about the patient and if he has any questions. Good morning, sir. How are you?
Fine, doctor.
I'm Dr. Mahmoud Hassan, cardiology assistant consultant. I'm here today to do a cardiovascular examination on you. If you don't mind, you have any problem with this? You agree? You agree, huh? Thank you, sir. Sir, can I know your name and your date of birth, please?
My name is Fernando Aviles.
Yeah,
My birthday is February 2, 1977.
77. Thank you, sir. You have any problem? You have
No.
any pain in any part on your body?
No, doctor.
Okay. You have any questions for me? Any inquiries about what we are going to do?
No, doctor.
Thank you. The next issue, we will ensure privacy of the patient and we will go for general inspection of the patient. Actually, cardiovascular examination does not start or even does not start with the use of stethoscope. Cardiovascular examination starts when you step in the room. When you are stepping in the room, you are looking for the general appearance of the patient. Does the patient look in pain, look in distress, look cyanosed, and has any special facial features, looks syndromatic like in Marfan syndrome or Down syndrome, Turner syndrome. We are looking in general for general inspection for this patient if he has any central cyanosis, distressed, does he look in pain? Actually, he looks fine, he looks comfort, he lies in 45 degrees in bed, no signs of pain or clenching of chest. The next issue, we will start with hand examination. While starting in hand examination, we are looking for signs of infective endocarditis like splinter hemorrhages, ossular nodules, genuine lesions. We are looking for capillary refill, tobacco staining, and any atrophic changes. And for finger clappings, just sir, can you do this for me, please? We are looking for clubbing of fingers. Clubbing of cardiovascular causes of clubbing of fingers include, that's enough, sir, cyanotic congenital heart disease and infective endocarditis. Sir, can you do this for me? We are looking for temperature bilaterally on both hands. That's okay for now. Thank you. After hand examination, we are going to examine the pulse. When we are examining the pulse, we are using the pulse of the middle three fingers. We are palpating the radial pulse here on the right side of the wrist joint. We are palpating like this. Here we are looking for rate and rhythm, volume. We are counting the beats in 30 seconds. Then we will multiply it by 2 to obtain heart rate in 1 minute. Now I find that you have heart rate about 35 beats in 30 seconds. Now I can tell the heart rate is 70 beats per minute. Then I will go to examine post-radial pulse at the same time to compare volume on both sides. And if there is a radial delay, this is one of the signs of aortic coarctation. After this, we will examine the brachial pulse. We are palpating the brachial artery, which is located medial to the tendon of biceps muscle. After this, I will go to assess for collapsing pulse. Sir, have you ever experienced any shoulder or limitation of movement in your shoulder pain or limitation of movement here?
No, doctor.
Okay. Thank you. With pulsations also, we are examining the carotid pulsation. Please, sir, can you relax your head here? We are examining the carotid artery pulsation. The carotid artery is located between the mandibular angle and the anterior border of the sternocleidomastoid. Before we starting to examine the carotid artery, we should auscultate the carotid first to rule out any carotid bruise. Here in the cystoscope, we have a diaphragm and we have a pill. We are auscultating the carotid artery with the pill of the cystoscope. There is no bruise. This is fine. When we are examining the carotid artery, we are examining each side separately. We don't do both sides at the same time. So we will examine the right side first. Then we will go for the left side. The next part of peripheral arterial examination, we are looking for abdominal aorta. Abdominal aorta, if we can, check here for any visible abdominal aortic pulsations above the umbilicus. Then we palpate the abdominal aorta. Abdominal aorta, sometimes it's clearly palpable in thin people, but if we can palpate it very easily, we may suspect that the patient has abdominal aortic aneurysm, and at this time we can ask for abdominal ultrasound. Then we will go to examine the femoral pulsations. Before doing femoral pulsations, I should explain to the patient what I am going to do, because I need to get the trouser a little bit down. Sir, I need to examine here and just a little bit down. Okay, that's enough. Enough, thank you. Here the femoral artery, we are examining the femoral artery. The femoral artery anatomy is located below the inguinal ligament. The surface anatomy of inguinal ligament is located between the anterior superior iliac spine and the pubic tubercle. It's in the middle third. With this surface anatomy, we can palpate the femoral artery. And simultaneously, we palpate the radial artery to check for radiofemoral delay. Note that femoral artery is the major site of coronary interventions, for even cardiovascular interventions like coronary or structural. So it's an important anatomical site to know and to identify. There is no radiofemoral delay. Thank you, sir. The next part of our cardiovascular examination is to examine the neck veins. Actually, neck vein examination is one of the most important part of cardiovascular examination. Neck veins, here we are examining the internal jugular vein. The importance of internal jugular vein, it gives us a hint about the volume status of the body. We know the internal jugular vein is directly connected to the innominate vein and with superior vena cava and directly to the right atrium without any valve. So any change in the volume status of the right atrium will directly affect the internal jugular vein. Here we are looking for, at the neck, we will see two pulsations. One pulsation is here and the other pulsation is here. Now we are comparing between the pulsations, the venous pulsations of the internal jugular vein and the carotid pulsations. In general, we should differentiate between the arterial pulsations and venous pulsation. In two methods, we will ask the patient to take a breath. With breathing, the venous pulsation will be affected and will be more prominent. The arterial pulsation will not be affected. The second issue, if we palpate the venous pulsations, we will feel no pulsations. It's only visible and non-palpable. However, in arterial pulsations, we can palpate it and we can feel the pulse. Sir, please, can you take a breath for me? Thank you. With breathing, with inspiration, the level of, or the waves of the venous pulsations became more prominent. While we are examining the venous pulsations, it looks like flickering by phasic waves. We can nominate it as an A wave, and the most common is A and V waves. We are looking for two positive waves, A and V wave. A wave stands for atrial contraction. The V wave stands for the right atrial filling during venous return. While we are examining the neck veins, we are looking, the patient should be in semi-recumbent, about 45 degrees. The head of the patient should be relaxed to relax the muscles. We are examining the veins here between the two heads of the sternocleidomastoid, the sternal head and the clavicular head. Here we can see we are searching for the upper limit of distension of these neck veins. We can see here, this is the neck vein pulsations, and here is the upper limit, the highest point of venous pulsations. Then we will go through this point, the sternal angle. We are checking how far this higher point of pulsations away from the sternal angle. I can tell it's about 3 centimeters. Then why we are searching for this sternal angle? Because this sternal angle is at the same level of the center of the right atrium. So if we have this level of distension, which is about 3 centimeters, and we still have another 5 centimeters down to the center of the right atrium, at this time we can tell that the central venous pressure is about 8 millimeter water, which is normal. The central venous pressure ranging from 8 to 13 millimeter water. While we are examining neck veins give us a huge amount of information. For example, we should define which is A and which is V wave. We are examining and observing the neck vein simultaneously while we are examining for the pulse. With pulse, the wave which comes before the pulse here is the A wave. The wave which comes after the pulse is the V wave. Okay, so this is A, V, A, V, A, V, A, V. One of the important information we can get from the neck vein examination as regard if there is a volume status in case of higher volume status, like in severe tricuspid regurg, right side heart failure, or hyperdynamic circulations, or even hypervolemia with excess IV fluids infusion. Also, we can see if we have, for example, if we have absent A wave. This happens in case of atrial fibrillation. We lost the atrial click, we lost the atrial contraction, so we will see only one wave comes after the pulse here in case of atrial fibrillation. Also, if we have a prominent V wave, this happens with severe tricuspid regurg. Actually, there is much more clinical findings we can search in the text. We cannot go through all of them, but the most prominent one, if we have absent A wave, this is a sign of atrial fibrillation. If we have prominent V wave, this is one of the signs of congestive heart failure, and in case of severe tricuspid regurgitation. Also, in case of one of the clinical findings is Canon A wave, we have a huge prominent A wave, which happens in some cases of complete heart block or nodal re-entry tachycardias. At this time, the atria and the ventricle contract at the same time, and it gives us a huge or Canon A wave. After examining the neck veins, we will go through the face examination. While we are examining the face of the patient, we are looking for facial symmetry, and then we will go for any signs of distress, any signs of pain, It's okay. Now we will go for eye examination. In eye examination, we are looking for densilismus, we are looking for arcus, and for pallor for in case of anemia. Then we will go for mouth examination. In mouth examination, we are looking for central cyanosis, angular stomatitis in case of anemias. And please, can you open your mouth, sir? We are looking for dental caries and oral hygiene because it's one of the risk factors for infective endocarditis, and we are looking for high arched palate. Open mercy. Okay, thank you. If the neck vein pulsations was not that clear, we can apply for hepatojugular reflux. Sir, you have any pain in your abdomen here?
No, sir.
Okay, I will just press a little bit. Okay, thank you. Okay, now it's became more prominent. Next, we will go for chest and pericardium examination. The first thing we are searching for by inspection, we are looking for chest wall deformities. If we have any deformities, any pectus externatum or cavatum, we are looking for scars. As a cardiologist and in cardiovascular examination, we are mainly concerned with medial sternotomy scars, which denotes that the patient has a previous cardiac surgery, either valve surgery or coronary artery bypass surgery. Also, we are looking for infraclavicular scars or bulging for pacemaker or cardiac devices like ICD or CRT. And we are searching for lateral thoracotomy scars on both sides. We don't have scars here. By inspection also, we are looking for any visible pulsations. To check for visible pulsations, we should look tangentially with the patient. We are searching for any visible pulsations, either apical, parasternal, or suprasternal, and we are looking also at the valve areas. Then we will go for palpation of the chest. First, when we start palpation, we are starting palpation with the whole palm, with the whole surface of the hand to have a general idea about the pulsation. Then we are searching for apical pulsations. Apical pulsations at the mitral area is defined at the outermost, lowermost palpable pulsations. We are palpating it with index and middle finger. I can't find it here in this side, so we should define the exact site of the apical pulsations or the mitral area. We will start here from the clavicle. Below the clavicle is the second intercostal space, then third intercostal space, fourth intercostal space, fifth intercostal space. So the apical pulsations is felt in this area in the fifth intercostal space, and when we are drawing a vertical line, we have here the midclavicular line, which is the normal anatomy of the palpable cardiac apex in the midclavicular line, fifth intercostal space. Then we will go with the heel of the hand to palpate for RV heave. That may denote that the patient has right ventricular hypertrophy or pulmonary hypertension. Then we palpate through the all areas in mitral area, tricuspid area, aortic area, and pulmonary area. Here we have, when we are examining the chest, many things are possible, and many things are possible. It gives us a lot of information. One of them is the acronym of this sentence. Many, we are looking from mitral area, T, things, tricuspid area, A, R, aortic area, then the pulmonary area. M, T, A, P. M, T, A, P. The mitral area, which the best site we can hear the murmurs of mitral valve, first and second, the first component of cardiac auscultation, S1. Here at the apical impulse, as we said before, in the fifth intercostal space, midclavicular line. Then T, tricuspid area, in the fifth intercostal space at the left sternal border. then A, aortic area at the second intercostal space at the right sternal edge. On the other side is P for pulmonary area at the second intercostal space at the left sternal edge. So when we are palpating, when we are auscultating, we go through this sequence: M, T, A, B, M, T, A, B. The normal heart sounds has two components, S1 and S2. S1 occurs with the closure of our tricuspid and mitral valves. S2 occurs with closure of the semilunar valves, aortic and pulmonary valve. So we have two components: S1 closure of tricuspid and mitral, and S2 closure of aortic and pulmonary. We should know physiologically that the mitral and the tricuspid valve close simultaneously at the same time. However, here the second component of cardiac sounds, closure of mitral, aortic and pulmonary, there is some delay because the pressure on the right side is lesser than the pressure on the left side. So if we can tell this is mitral and tricuspid, they develop the component of S1 at the same time. However, here there is a certain delay between the aorta and pulmonary valve. So there is what we can call it a splitting of S2. So if we hear S2 here in the aorta, we will hear it as one component. But if we go to auscultate here in the pulmonary area, we will hear a splitting, because we will hear the aortic component and the pulmonary component, which is a physiological process. Here S1, and at this side in S2 there is the aortic component, then the pulmonary component. In case the patient take deep inspiration, with deep inspiration the negative pressure intrathoracic will increase, the venous return will increase, the volume on the right side will increase, so there is more delay of the pulmonary component. So you can see S1 and aortic component and the pulmonary component will go far away from this, and we can tell it's why the splitting of S2 with deep inspiration. In one of the pathological conditions, in case of left bundle, in left bundle there is a delay of the aortic component, because in left bundle there is a delay in depolarization and contraction of the left ventricle in comparison to the right ventricle. So the aortic component will be delayed. We will hear first the pulmonary component of S2, then the aortic component will be heard. The splitting will be reversed. With deep inspiration, the pulmonary component also will be delayed and it will be more close to the aortic component. That is we are calling reversed splitting. This is one of the physiological features that we can observe here in heart sounds. Also, while we are examining, we are defining S1 and S2. This is part of the cardiac cycle to identify if we have an added sounds or a murmur, that we know at which time of cardiac cycle this murmurs occurs. Closure of mitral and tricuspid valve, which is S1, this occurs with the beginning of systole. So from S1 up to S2, this part of cardiac cycle is called systole. From S2 and again to S1, this is the diastole. So if we have abnormal sound or additional sound or murmur be just starting after S1 and occurred or ended before S2, this is a diastolic murmur. And if we have a murmur that occurs after S1 and occurs after S2 and till S1, this is a diastolic murmur. So how can we define that is S1 or S2? By auscultating the beats here, and we are examining at the same time the carotid. The sounds that we hear by stethoscope and come with the carotid pulsations, this is what we call S1. The second one is the S2. Also from the added sounds, we have two added sounds, S4 and S3. S4, we can hear it physiologically. It happens when the left ventricle during diastole, now it's fully it's full, and at the time of atrial contraction, the atrial contract blood into a full left ventricle, which can cause an additional sounds, and it happens immediately before S1. And in case of a rapid filling from the left atrium to the left ventricle, if we have weak or cardiomyopathy, there is a fluttering of the myocardium, which with rapid filling phase of in diastology, that may result in occurrence of S3. So we may have, normally physiologically we have S1, S2, we may have added sounds S3 or S4. At pulmonary site we have splitting of second heart sound. We now and later on we will search if the patient had the murmurs, either systolic murmur or diastolic murmur. If the murmur between S1 and S2 is systolic, between S2 and again to S1 is diastolic murmur. When we are hearing a murmur, we should define which site, which the valve that is responsible for this murmur. Physically, we can hear that, for example, if we have a mitral murmur, for example, mitral regurgitation, which mitral regurg in systole should be closed, and it's not probably closed, so we will hear a regurgent of blood, the sound of regurgent of blood from the left ventricle to the left atrium, so we will hear a murmur. At this site, at this time, if we are auscultating all the valve areas, we will see that the maximum intensity of this sound will occur at the mitral area here. Okay, and if we propagate with the stethoscope towards the axilla, the sound will be propagated, because physically the sound wave propagation from the left atrium to the left ventricle will go for this direction. So if we go far with the stethoscope at this time, we will hear the sound more accentuated. Also, one of the features or maneuvers we can do to accentuate mitral or left-sided murmurs, it will accentuate it during expiration. So with expiration, also the murmur will be more accentuated. Another example, if we have aortic murmur, for example, for aortic stenosis, the valve is not open properly. So during systole, the valve is not adequately open, and with passage of blood through the left ventricle to the aorta, this will cause turbulence and will cause a murmur. At this time, we will hear a murmur with maximum intensity will be at the aortic area, and physiologically or physically, this is the direction of the blood flow in this direction. So with this direction, the sound of the murmur will be accentuated to reach here at the base of the neck at the carotid area. So the propagation of sound will be accentuated here in the carotid area. For this example, if we have a murmur and it's a systolic murmur and we don't know is it mitral regurgitation or aortic stenosis, we will hear both in the aortic area and the mitral area. We will see which is the maximum site of intensity, and we will see the propagation. If we have a mitral regurgitation, the maximum intensity here will be at the mitral area, and if we go with the stethoscope and give the patient on the bring the patient on the lateral position, the sound will be accentuated. If we will do the reverse, the sound will diminish. Okay, in case of aortic stenosis, if we hear the maximum intensity here in the aortic area, the propagation of sound will be accentuated more towards the neck, and if we go in this direction, the sound will be diminished. At this time, we can now tell it is mitral regurgitation or aortic stenosis. The reverse also occurs between the tricuspid valve and the pulmonary valve. When we are starting auscultation of the chest, we have here our stethoscope. It has a diaphragm and a bell. This bell is equipped or suitable for low pitched sounds. The diaphragm is suitable for high pitched sounds. Low pitched sounds is a physiological S1 and S2, and also in case we are searching for S3 or S4. So in auscultation, we will start with the bell of the stethoscope, then we will go with the diaphragm. When we are adjusting our stethoscope, we make it in this direction to be equipped to the direction of our auditory canals. Then we will start with auscultating the mitral area here with the bell of the stethoscope, and we are listening to S1 and S2. To define which is S1 or S2, please sir, I will palpate your carotid at the same time. We are palpating the carotid artery. The sound which I am hearing at the same time of the carotid pulsations is S1, and the second one is the second heart sound. So I can hear now S1, S2, and I can time it with the carotid pulsation from mitral area, M, then to tricuspid area, T, A, aorta, B. At the pulmonary area, I can hear the splitting of the second heart sound. I can hear it as a two components. Please, sir, can you have a deep breath? Hold, please. At this time, I can hear it more clear. The splitting of the second heart sounds at the pulmonary area, it's now more prominent. Okay, breathe normally. Thank you. Then I will go with the diaphragm. With the same sequence, M, T, A, B. M, T, A, B. Then again, with the bell of the stethoscope, I'm searching for the low-pitched sound of the diastolic murmur of mitral stenosis. And at the maneuver to accentuate mitral murmurs, I'm asking the patient to be on his left side. Please, can you sir, be a little bit on left side? Enough, thank you. Now I can hear the sound is more accentuated, and I'm propagating it toward the axilla for searching for any murmurs propagation. Thank you, sir. Come back again. Then, if we have any murmurs at the aortic area and second aortic area, please can you sit down, please? One of the maneuvers to accentuate, sit down, please, sit down, accentuate the aortic murmurs, if we can lean the patient forward and we can hear for murmurs of aortic regurgitation. Please, can you please take a deep in-breath and exhale, exhale, okay, hold please. During expiration, if we have murmur for aortic regurgitation, it can be accentuated by leaning the patient forward during expiration. Here I'm auscultating in the second aortic area in the third intercostal space at the left sternal border, and also in the original or the first aortic area in the second space in the right sternal border. Thank you, sir. So in brief, we are starting auscultation of the chest by regular sites and rotational site in mitral, tricuspid, aortic, pulmonary, MTAP, MTAP. We are defining or identifying the first and second heart sound S1 and S2 by timing it with palpation and feeling the carotid pulsations. The impulse we hear at the same time of carotid pulsations, this is S1. The second one is the second heart sound. Now we will define first and second heart sounds in the mitral area, in tricuspid area, in aorta, and in pulmonary. We are now looking for any murmurs or added sounds like S1 or S4. Then we will go for murmurs. For if we have a murmur, we have abnormal sounds that covers or comes in between S1 or S2. We should define at which timing of this murmur. Is it systolic or diastolic? If the sound comes between S1 and S2, it's a systolic murmur. If the sound comes between S2 and S1 of the second cycle, this is the systolic murmur. If we hear a murmur and we timing it, is it systolic or diastolic, we are searching for what is the origin of this murmur. The murmur, it has a maximum intensity. We will see which area has a maximum intensity of this murmur. We are looking also for the four areas in mitral, tricuspid, aortic, pulmonary. Where is the maximum intensity? Where is the propagation? For example, in mitral murmurs, it's propagated to axilla. In aortic murmurs, it's propagated to the carotid with certain maneuvers like inspiration or expiration. A right-sided murmur, tricuspid or pulmonary, either tricuspid stenosis or regurg, pulmonary stenosis or regurg, the murmur will be accentuated with inspiration. In left-sided murmurs, mitral valve disease or aortic valve disease, the murmurs will be accentuated during expiration. After we did timing and maximum intensity, propagation, special maneuvers, we can just grade the murmur. The murmurs murmurs we are hearing has a 6 grades. Grade 1, the murmur is barely audible. In grade 2, the murmur is hardly audible. In grade 3, the murmur is clearly audible. In grade 4 of murmurs, the murmur is clearly audible and has a thrill. With the thrill, we should, again, if we hear the murmur, for grading it, we should palpate the whole areas for thrill. Thrill means there is a palpable murmur. We will feel like vibrations at this site. We are palpating the mitral area, tricuspid area, aortic area, and pulmonary area. If we have a thrill with the murmur in any part of these areas, so this murmur is about grade 4/6. And clearly audible and loud murmurs with a thrill also, it's a grade 5. In grade 6 murmur, 6/6, it's a very loud murmurs. Even we can hear it while the stethoscope is not attached to the chest wall at all. And this type of murmurs is not present outside because we have an advancement in cardiac surgeries, and we don't let the patient with valve disease to develop such type of murmurs for a long time. We have now an intervention at early stages of valve disease. We don't wait too much time to have this phenomena. The next part of auscultation, we are auscultating the back of the patient. In auscultation of the back, we are hearing 2 breath sounds, and we are checking for any crackles or pulmonary crackles, which may denote that the patient had a left side heart failure and pulmonary congestion. We are starting auscultation of the back from the basal lung fields. Sir, can you please take a breath, please? Okay, we are auscultating. Okay, breathe normally. In and out, yeah, please. Take a breath. In and out. Okay, out. In. Out. In. Out. In. Out. In. Out. Here also from the lateral lung fields. In and out, please. Breathe normally, yeah. Deep inspiration and expiration now. Again. 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 If we found that the patient had the crackles, we should define at which level the crackles are there. So if we have a basal crackles or mid-zone crackles or crackles up to the upper lung zones. Also, as a part of PAC examination, we are, please sir, I will breathe a little bit here in your sacrum. We are checking for sacral edema in patient with prolonged bed recumbency or bed-bound patient. We are little bit breathing here on the sacral area and checking for any indentation or sacral edema at this site. And this happens in patient with prolonged recumbency and right side heart failure. We may find here sacral edema. Okay, thank you, sir. The last part of our cardiovascular examination today, we will look for the lower limbs. In lower limbs, we will check for peripheral pulsations of posterior tibial artery pulsations on both sides, and dorsalis pedis pulsation here on both sides. We are looking for atrophic changes, peripheral ischemic changes, and venous sufficiency. If we have distal ischemias, and we are looking for pedal edema. Sir, if I press here, you have any pain here? Thank you. I'm with little bit breathing here. We are checking for lower limb edema, which occurs with right side heart failure, one of the peripheral signs of right side ventricular failure. There is no. Now, sir, we came to the end of our cardiovascular examination today. I really thank you very much. I'm appreciating your help and cooperation. Thank you, sir, very much.
Welcome, doctor.
Thank you. After finishing examination, also again we will go for hand washing, and I will summarize my findings. Mr. Fernando is a 45 or 46-year-old male patient. He came to cardiovascular examination. Patient general looks fine. He is not in distress or in pain. His heart rate about 70 beats per minute. Cardiac examination, he had a normal S1, S2, no added sounds, no murmurs. He has normal breath sounds, no crackles or pulmonary congestion. There is no lower limb edema. Peripheral pulsations are intact. To complete cardiovascular examination, we should review his ECG, chest X-ray, and measure again his blood pressure and check for any further investigations. We will send him, for example, if we find that he has a murmur or any abnormal findings, we can send him for further cardiac investigations like echocardiography or any other cardiac investigations. By this, I hope we covered the required information and required skills that the undergraduate medical students need to know and need to apply in his future exams in cardiovascular examination. I hope I covered it properly, and I'm asking you if we are seeking for, we cannot cover all the required information and knowledge in a video of 30 or 45 minutes. This may need, if we go for more details, it may need hours or even days to complete the whole cardiovascular examination with the whole maneuvers or whole abnormalities. But I hope we covered the required summary of cardiovascular examination. أخيرا أسأل الله عز وجل أن يكون العمل خالصا لوجه الكريم، ويكون في استفادة مرجوة إن شاء الله لأبنائنا الطلبة، وشكرا جزيلا. السلام عليكم.